Juste quelques mots en français pour introduire le professeur Steve Graham. So Steve, it's a welcome here. We are really happy to have you here. So Professor Steve Graham is a pediatrician from Australia. He's working at the Center for Center for International Child Health, University of Melbourne, Australia. He has been working for a long time in Africa, in Malawi, caring for children with pneumonia and TB. And he has done a lot of research and clinical and advocacy work in the field of childhood TB. He was the head of the committee who wrote the guidelines for childhood TB in 2014. He has worked with the union, and he still works with the union, the International Union Against TB. And he's supporting one of our projects here. He's the Scientific Advisory Board Chair for one of our projects, so supporting us also. It's really a pleasure to have him here to tell you about childhood pneumonia, which, as you may know, was for long and is still probably the first cause of death in children below the age of 5 in the world. So, Steve, you have the floor.
Perfect. Thank you. Thanks very much, Olivier. It's a pleasure to be here in Bordeaux. No, this is fine for my first time. I apologise that I'll be speaking in Australian. I did learn French when I was at school for 3 years, but you can see that was a long time ago. So, but we will be talking about the problems of child pneumonia. And as Olivier said, that particularly when I first worked in Malawi in the 1990s, I was in Malawi for 12 years, the focus of my work particularly was on child pneumonia and the consequences of HIV-related pneumonia. That was the focus of my PhD. I'll be talking about child pneumonia because pneumonia is still the major cause of death in children under 5 globally. So it's an important disease. And when we talk about pneumonia, I'm talking about infections of the lower respiratory tract. We're not specifically talking about bacterial pneumonia or viral pneumonia or the particular cause. We're just talking about the clinical problem of lower respiratory tract infections. And you can see from this particular WHO publication, the burden of pneumonia is particularly in the resource-limited settings in terms of incidence, in terms of frequency of pneumonia in young children, and in terms of pneumonia-related mortality is particularly high also in those particular settings. So most of the deaths of child pneumonia still occur in sub-Saharan Africa, but most of the cases of child pneumonia, because of the large populations, occur in Asia, but also has particularly in the South Asia and Southeast Asian region. So it's important to recognise, because we will be talking a little bit about tuberculosis as well further on, but the places where we see a lot of child pneumonia are also the same settings where you have a lot of child TB. You also have a lot of malnutrition in children. You also have more HIV in children. So, and you have more poverty, you have more of the risk factors for social determinants for child pneumonia, such as poverty, poor access to care, etc. So there is a big overlap, and it's quite challenging, as we'll discuss, in terms of your diagnosis, in trying to evaluate the sick child in those settings who may present with pneumonia as to what might be the cause, what's the particular specific treatment, how we can prevent, how we can manage. But there is a big overlap in the issues. So some years ago, and I'm talking more than 20 years ago now, there was quite a few studies done to try and find out what were the causes of pneumonia in young children. And they used to do studies of putting needles into the chest to try and aspirate some fluid for culture to try and understand better what might be the causes. Which causes particularly we focused on? The ones that we might be able to prevent, the ones we might be able to treat better with antibiotics. And you can see from those studies some time ago that bacterial pneumonia was a major challenge, particularly from pneumococcus, Haemophilus, and other bacteria. So that's the focus of your treatment for antibiotics, and that's also now the focus of vaccines to try and prevent these sorts of cases. But there's always been a lot of children who present with viral pneumonia. And in Bordeaux here, I'm sure at the hospital in the children's, most of the cases, as is the case in Melbourne in Australia, most of the children presenting with pneumonia, it's due to viruses. Where there's a high morbidity and perhaps a need for hospitalisation, but often a lower mortality, and questions the need or not for antibiotics. So RSV, particularly respiratory syncytial virus, we're all familiar with the presentation of bronchiolitis and other presentations, and RSV is now the focus of vaccine development because of its importance, not as a cause of death so much in pneumonia, but as a cause of hospitalisation and frequent illness in young children. Similarly, influenza. We've just had a very big influenza season in Melbourne. There's been a lot of children admitted to hospital and to intensive care with influenza and influenza-related illness. You'll notice that in this particular slide there is no mention of tuberculosis, because the studies that were done, there was no diagnostics that were used to look for tuberculosis. But around the same time, there was autopsy studies being done in Africa, and it was clear that children were dying of pneumonia and after death were being identified as having tuberculosis. It wasn't identified before they died, but clearly tuberculosis was playing a role in the presentation of child pneumonia. So this is a more recent review of the issues for child pneumonia, and I think it's great to know that as one of the contributors to the Millennium Development Goals of reducing child mortality, the reduction in child pneumonia and child pneumonia deaths has been really important. And it's not just about clinical management, it's a reduction in other factors as well. It's a reduction in risk factors for pneumonia if you have improved socioeconomic development, less crowding, less malnutrition, you will have less severe cases of pneumonia. We now have vaccines to prevent bacterial pneumonia, such as Haemophilus, pneumococcal vaccine, which I'll spend some time on. And these are added now to the vaccines that have been around for a long time, which are really important in reducing pneumonia deaths, particularly measles. In Malawi in the 1970s, the major cause of death in children was measles. And you don't see much measles so much anymore. You do see cases, but those children often died with pneumonia. And pertussis, other vaccines. But more recently, we've had the bacterial conjugate vaccines, and that's been important. The other important contributor to the reduction in child mortality due to pneumonia, particularly in sub-Saharan Africa, has been the prevention to mother-to-child transmission of HIV. So we do not have, compared to when I first went to Malawi in the 90s, we don't have the same numbers of children being born with HIV anymore, which is fantastic. And those that are exposed, they have cotrimoxazole preventive therapy, early ARTs, other interventions which reduce pneumocystis and other nasty infections causing death. So that's also been an important intervention. Now, just recently published was a large multi-centre study funded by Bill and Melinda Gates, which has tried to go back to many settings in the world and look again, what are the causes of pneumonia now compared to 20 or 30 years ago. I think most of us would agree that this study hasn't really told us anything we didn't already know. But I think it's important to recognise that viruses are probably now the major cause of pneumonia globally. The case fatality in this particular group was 6.4%, which is lower than what it used to be for pneumonia. And viruses make up a substantial proportion, but also, interestingly, because they look for it, you find tuberculosis as a not insignificant cause in terms of something that is treatable and preventable. So these were the findings of the Perch study, just recently published in The Lancet. So one of the challenges of addressing child pneumonia has been there is no forum in the world, except maybe at the union meetings, but there is no forum in the world where people come together and talk about child pneumonia. There are meetings that talk about pneumococcus. There are meetings that talk about RSV. There are meetings that talk about tuberculosis or HIV, but nobody just comes together to talk about child pneumonia. We need, in infectious diseases in children, point-of-care tests. It would be fantastic, clearly, to have a test that we could do, maybe a finger prick test, when that child presents with pneumonia, to be able to decide what is the cause of pneumonia in that particular child. We don't have that, and we're a long way from that. Even blood culture is a very low sensitive test for this type of scenario, for bacterial pneumonia. We recognise that the groups with the highest risk of mortality are those with comorbidities, malnourished, HIV, other cardiac disease, other types of problems. But some of the common issues why I say it's important to come together for child pneumonia is that some of the issues, it doesn't really matter what the cause is. The issues are the same in terms of access to care, in terms of case management, such as the provision of oxygen or the detection of hypoxemia. Hypoxemia is associated with mortality for child pneumonia, we know that. But there are many settings where children present with pneumonia that is severe, but there is no oxygen available for treatment. So these are sorts of the issues, and then particularly in Asia, as I referred to, one of the challenges also now we live in the world of concerns about the emergence of antimicrobial resistance. Can we do better with antibiotics usage in child pneumonia? That's a difficult question. So just as one example, in Vietnam, in terms of vaccines, in Vietnam there was no data about what were the causes of pneumonia, such as Haemophilus or pneumococcus or whatever, but they did actually introduce in one province the Haemophilus vaccine and found a significant reduction in pneumonia overall, radiologically confirmed. So it was an indication that even though you don't know because of the poor diagnostics to know what the causes of your pneumonia are, it would suggest that an intervention that targets a particular cause like Haemophilus actually could make a difference. But it's difficult in many resource-limited settings to understand. So we think the major bacterial cause is pneumococcus, and we think that in the same as those other maps, the areas where we think it's most likely causing most deaths is in the sub-Saharan African, South Asia, Southeast Asian region. And we do recognise now that the introduction of vaccines for pneumococcus in Haemophilus has made a significant impact on reducing disease and death due to pneumonia, but also due to meningitis and also other sepsis. So that's really had a very, very important impact. The problem is we don't have a lot of data as to the burden of, for reasons I suggested earlier, how much pneumococcal pneumonia is there in many populations. We assume that there's a lot, and I think it's probably a fair assumption. But vaccines is certainly one way of making a difference. Interestingly, I just put this up because this is just what's happened in terms of changes in mortality relating to pneumonia in low and middle income countries, is this recent publication suggested that there's been a reduction in case fatality, as you would expect. When I first went to Malawi in the hospital I worked, the case fatality for severe pneumonia was 20%, or it could be 10 to 20%. Now it's less than 5%, or around 5%. So things have changed a lot for lots of different reasons, but there's been a reduction in case fatality. At the same time, they've noticed there's been an increase in numbers of children being admitted to hospital for pneumonia. I'm not sure what that relates to, whether it relates to just improving access to care, or in countries such as Vietnam, where we've been doing some work, there is a lot of pressure by families when a child is sick with respiratory disease for them to be hospitalised, to get the right care, etc. So there is perhaps improving access to care, but hospitalisation is not necessary for most children with pneumonia. They should really be managed as outpatients. And pneumonia, the point I'm making, I guess, is that pneumonia has a huge impact on morbidity. It's the commonest cause of hospital admission in most countries, and that's a huge cost to health systems that many times I think is perhaps unnecessary. In recognition of this, WHO has redefined their definitions of management for pneumonia so that now, since 2013, only children with danger signs, they might have fast breathing, chest indrawing, but they need to have danger signs such as poor feeding, hypoxemia, reduced level of consciousness, etc., before they actually get admitted to hospital for intravenous or parenteral antibiotics. If the child just has fast breathing and chest indrawing, clinical diagnosis of pneumonia, and you want to use antibiotics, you can treat those children as outpatients. They don't need to be hospitalised, which is a major change to what it was previously. So this is should be having a marked impact on the epidemiology of hospital care for pneumonia. Now, let's just spend a bit of time on vaccines quickly. I'm going to make sure I go over time. The pneumococcal conjugate vaccine, targeting effectively the most commonest cause of bacterial pneumonia in children, the most commonest cause of mortality due to bacterial pneumonia in children, should be a no-brainer, though some countries are still not convinced it's necessary because they have no data as to the burden of pneumococcal disease. But one of the challenges for pneumococcal conjugate vaccine, and I won't go into the story as to why this happened, but it's expensive. So it has to be funded from outside. Low-income countries cannot afford this vaccine. It needs to be funded from elsewhere. And this is just some data from Gavi, which is the Global Vaccine Initiative, just to show you as an example, compared to other vaccines that are listed, how much pneumococcus is the major need for funding to be able to roll out vaccines. It's an expensive vaccine. The companies that have produced this vaccine have done very well. So there's a couple of issues. Countries want to know, before they invest in this vaccine or decide to adopt this vaccine, what will be the impact? And we know that pneumococcus has many serotypes, but the vaccine is only covering 7 or 9 or 10 or 13. And what will happen once we've introduced it? Will the other types of pneumococcus that are not covered come and replace the ones that you're trying to prevent? And so there is a need for more surveillance. There's definitely the case. It's really hard to detect invasive disease due to pneumococcus. You can do your blood cultures, but it will only be positive probably in less than 10%. You might be able to monitor meningitis better, but for pneumonia it's challenging. So one way of the group in Melbourne have been doing is they've been using nasopharyngeal carriage as a proxy. Not ideal, but it's certainly much easier to get pneumococcus from throat swab, nasopharyngeal aspirates. But there's a whole lack of problems and data and case definitions and et cetera, et cetera. So there's many challenges. One of the things that the group in Melbourne have been looking at, working with Australian government funding and working in Fiji and Vietnam, is, okay, it's an expensive vaccine. We generally give it to young children 3 times, but can we actually do better than that by giving it just 2 times? Or even once when they're young, and then later when they're older give a booster with the old-fashioned cheap pneumococcal vaccine that's been around for a long time. So there is work in trying to look at these are just some examples. I mean, PCV10, for example, in Vietnam, a study looking at 1+1, giving a PCV early as in 6 weeks, and then giving a booster later on, versus 2+1 versus different schedules. Because what's driving this is really a way of getting to an equally effective or perhaps even more effective schedule that is cheaper than the current one. And this is another example of work that our group is doing in Mongolia of just of a cluster randomised intervention to introduce a 13-valent impact study, which is very much supported by the Mongolian government. And again, you'll see that in terms of primary objectives, it's almost impossible to measure the impact on bacteriologically confirmed pneumococcal pneumonia. So what you need to do is use a proxy, and the proxy there is incidence of radiological pneumonia. And then in Laos, another bit of work being led by my colleague Fiona Russell is actually just monitoring over time carriage serotypes of pneumococcus. And what they've found, what this will show you, is that over time, over the first few years since introduction, the percentage of vaccine serotypes in that community and looking at non-vaccine serotypes, and this didn't change for 3 or 4 years, but after 5 years, suddenly there's now an increase in non-vaccine serotypes. So we do expect that there probably will be a replacement of the vaccine serotypes by non-vaccine serotypes. What consequences that is for disease, we still don't really understand. And I think it's also important to remember there is another very high-risk group in these communities, or a number of other high-risk groups in the community, such as people living with HIV, but also old people. Pneumococcal pneumonia is one of the old people's best friends to take them to death. And in the whole point of introducing vaccines of young children in the communities and reducing carriage of vaccine is reducing transmission in the whole community and risk for other at-risk groups. Sorry. Another way of measuring the impact is, such as this work in Papua New Guinea, is just to look at the impact on hypoxic pneumonia. So hypoxic pneumonia is common in Papua New Guinea and the highlands. Pneumonia is a major problem in particularly pneumococcal pneumonia. And there's a lot of hypoxic pneumonia, which is easier to measure. If you have oximetry, that's a fairly straightforward tool. And what they've found is in the introduction of a pneumococcal conjugate vaccine, there's been a significant reduction in hypoxic pneumonia. So there are different ways of trying to measure impact. I'd like now to move towards a discussion around antibiotics. This is work that's been done by a PhD student with the university who works in central Vietnam in Da Nang. And the work that she's done is basically just looked at 1 year of admissions to her hospital of children with a diagnosis of pneumonia. And I do say pneumonia in inverted commas. And what she's shown is that actually the vast majority of children being admitted to that hospital would not fit the WHO criteria for severe pneumonia. There are a lot of children being admitted to hospital and receiving intravenous antibiotics for 5, 6, 7 days who actually probably don't even need to be in hospital. And you would even question whether they need to have antibiotics. Very, very low mortality, but large numbers of children. And there's a lot of pressure in that hospital from the medical administrators and for the practices of physicians as an income-generating activity. There's a lot of parental anxiety. There's a lot of push to put children onto beds and have them in hospital. And so this is the sort of work that she's doing. So her data, she goes back to present her data and she gets in trouble because she's criticising her own health system. But this is interesting and a little bit challenging. But it's an interesting issue. And so I don't expect you to read all this, but the basic finding is, I think I've already said this, that probably in her setting, the unnecessary hospitalisation and the unnecessary use of antibiotics, particularly parenteral antibiotics, is a major cost and burden on the health systems, which is totally probably preventable. And also hospitalisation is, as you know, is not without its risks. Children go into hospital with one disease, and then because they're in hospital, they get nosocomial infection, and they go home with something else. So this is the work that she's been doing. And this is really just showing you that a lot of these children don't have pneumonia by WHO criteria. A lot of them have wheeze. Hypoxia is not in those that was not measured in many, but and many of them actually. Normally, we don't do a chest X-ray as routine, for example, in Malawi for a child with pneumonia, but in Vietnam they do, and you can see that half of the chest X-rays are normal. So it's difficult to understand what this population really represents. Other challenges in high-risk areas is, as I've already said, I think children with comorbidities such as malnutrition, HIV, cardiac disease, neurological disease, these other types of problems we recognise. Something that is becoming increasingly common, or certainly I noticed over 20 years, increasingly common, including in Malawi, was infections with nasty gram-negatives such as Klebsiella, Acinetobacter, multi-drug resistant, outbreaks in the newborn care settings, outbreaks in the malnutrition wards. There's a lot of hospital-acquired infection. Not surprising because you've got difficult issues of infection control in overcrowded wards. We used to have three children sharing each bed in Malawi. That was common. So, as I said, they may come into hospital with one severe disease and then go out with carrying something else. So hospital-acquired infection is an important issue. Multi-drug resistance, gram-negatives, and then, of course, TB. So for TB, we know from various studies, particularly in the African region, that were put together by Jackie Aliwa from Kenya in this systematic review, that when they were looking for TB in children with severe pneumonia, whether that was in Malawi, Uganda, South Africa, quite a substantial number actually had TB, including bacteriologically culture-positive TB when they looked for it. And it may not seem that around 10% or 11% with a clinical or confirmed TB is a large proportion, but of all these many pneumonia cases, that's a lot of TB. And in terms of clinical importance, TB is a preventable and treatable disease. So this is important, and this supports the previous autopsy study that was done, autopsy studies that were done in the region. And most of these children were not presenting with chronic cough, but they were presenting with acute cough and respiratory distress. So, as Olivia mentioned when introducing, and also with others here like Olivia, Eric, Marilyn and others, we've worked hard over the last 10 years or more to get more attention to the problems of TB in children. This is really, really important because TB is actually a major cause of morbidity and mortality in many low and middle income countries. Wherever there's a lot of TB in adults, there'll be TB in children. People in the programs and public health people have not always given much concern to TB in children because particularly young children, even though it may be common and even though it's a cause of death, young children with TB are not responsible for transmitting in the community. So as a public health risk, they are low risk. But our focus has been to put TB into the context of child mortality. And that's important. And in fact, you could put it into the context of maternal, child and adolescent health. And for some of the reasons that I've listed there. As diseases like pneumococcus and Haemophilus and measles have become less common, as a cause of morbidity and mortality that is both treatable and preventable, tuberculosis is relatively more important. It's important for pregnancy-related TB. Pregnancy is a risk time for tuberculosis, and if you develop TB during pregnancy, it has impact upon your outcome of pregnancy, including of the fetus, of the newborn, etc. So there are quite a few negative impacts. There's a lot of indirect consequences of TB in children, particularly all of those children who have lost parents to TB. And TB, in many low-income settings, if there's a case of TB in the household, in 60-70% of those households, it will take that household into poverty. So taking a household into poverty where there's young children in that household also has a lot of consequences. And then TB in adolescents only recently has been recognised as a risk group both for infection and for disease and perhaps for poor outcomes. And TB in adolescents is important from a public health point of view because when adolescents develop TB, like adults, they often transmit in the community. So we've developed roadmaps, including now, more specifically recently, including adolescents. Eventually paediatricians start to move away from under 5 and start to engage the adolescents. And adolescent health is a real challenge in low-income settings because adolescents struggle. They fall between the cracks of whether they access child health services or adult health services. And often they're not comfortable in either setting, and it's a big challenge in terms of stigma, in terms of treatment adherence, in terms of access to care. So this is just old data from a long time ago, which has been shown time and time again. Why we worry about young children? If a child's infected with TB, exposed, infected, and they're under 5, particularly infants, they have a very high risk of developing disease. But so do adolescents. The risk goes up again. And the red bar is severe disseminated disease. Now BCG, the BCG vaccine has reduced the red bars and reduced the amount of TB meningitis and severe forms of TB, but has not done very much for the green bars. So we have a big problem in young children. Also a challenge for diagnosis as well as prevention. One area that we'd focus on in terms of identifying children for TB with early disease and get them onto treatment is to do household screening, such as I'm sure is done in France. Whenever there's a TB case identified, the public health nurses go to the households and screen because you will find other cases of TB in that context. And in Uganda, this study done by colleagues of Eric's and others showed a very, very high numbers of children in those households with TB. And the other challenge we have is the detection, more and more cases of multi-drug resistant TB in the world, but young children are difficult to get bacteriological confirmation. If you can't get bacteriological confirmation, you can't decide whether it's MDR or drug susceptible. So we have to make assumptions about how much MDR TB, multi-drug resistant TB we have. But we think it's probably just as common if there's a lot of MDR in the community, and the prevalence will be reflected on the numbers of cases in children. And MDR TB is nasty. It requires long treatment regimens. Up until recently, it requires injections every day for 6 months. It's hugely expensive for the families and for the program, etc. So there's many, many challenges and we still have to make often a clinical diagnosis just on the basis of a contact history of somebody with MDR. So that's another challenge. So, obvious statement, clinical challenges are the same ones as the diagnostic challenges. What I mean by this is that these are the groups who have risks for TB, but they're also the groups that have risks for mortality. And that's a critical issue and the hardest to diagnose. So, we talk about the development of rapid diagnostics, which is sort of work that's been done by Olivia and the group here in Bordeaux. But this is the rapid development of diagnostics. And the rapid development of diagnostics happened more than 100 years ago. So we still rely on diagnostics that were developed 120, 130 years ago to try and help us with a diagnosis of TB. And that speaks volumes about the fact that TB is a disease of poor communities in low resource settings who cannot advocate so that investment in R&D doesn't go to TB. And that's a big need. So even with the new diagnostics such as ISPED, which is the most important advance in recent times because it can identify more cases than microscopy, even with that technology, we have to recognise that children don't produce a lot of bacilli. So even ISPED will only be positive in, at best, maybe 30% of your TB cases with pulmonary TB, and you still have to make a clinical diagnosis in many of the children on the basis of symptoms and contact history, chest x-ray, etc. So it cannot rule out TB. A negative ISPED does not mean the child doesn't have TB. But it does help, and it does help in terms of identifying cases, and it helps in terms of identifying, because it also tests for rifampicin resistance, it can give us some information about drug susceptibility. So these are some of the issues, and most of the studies that have been done until recently on child TB have been done in large teaching hospitals. In Malawi, I worked in Malawi's largest hospital. Eric works in the largest hospital, I think probably a paediatric hospital in Uganda, in Kampala. But children with TB, they don't make their way to the biggest hospital in the country. Most of them will actually first present to the primary healthcare setting or maybe to the district hospital in the rural areas, etc. So how do we actually strengthen detection and treatment at that level? And that's really, I don't have any answers, but that's a challenge. You need to get to the point where the child has early diagnosis and treatment, and that cannot wait until they get referred all the way to the biggest hospital in the country. That's clearly not going to work. So there's lots of challenges. We've talked about high-risk populations, such as household contacts, people living with HIV. In the region where I come from, particularly in the Pacific Islands, diabetes mellitus is a massive issue, and diabetes is a risk factor for TB disease. But what we really want to be working towards, and I refer again to the work that's being led here, is to some more point-of-care sampling and rapid diagnosis, if we can. We're still a long way away, but we're working in that direction. We're fortunate now that we have better treatments for child TB. We've developed in recent years dispersible tablets of the right dosages that you can drop into water and the child can just drink them, can take them home as tablets, and they work very nicely. And we need to be able to move from siloed disease approaches to where, because child TB doesn't present to TB services, it presents to child health services. And we have to integrate much better the care and the management. You've got an adult with smear-positive TB. We should be able to work our health systems, our community health workers and everything to provide that whole family with appropriate care for everybody within that family, and not silo out the adults, go that way, the children go that way, and everything else is challenging. So I want to refer to some of my colleagues in the room. Basant Joshi, who's here, is from Nepal. He's doing a PhD with the TB Speed project. He's done some work on case finding strategies, and his work, the summary of it was that household for children, go to households is probably going to be the best yield for case finding. Marilyn, her work with households has been done in southern Uganda, and what we're trying to do, and including studies that Marilyn is also involved in, is to try and improve household contact screening implementation in resource-limited settings, to be able to detect cases of TB in children, but also to be able to provide preventive therapy. And so Olivia has led work that was called the Panther study, and the reason why this work has been important is because it talks to the issue of trying to get improving diagnostics, such as in HIV-infected children, you can't send them all off for induced sputum or to the hospital for gastric aspirate. Can we do better with just getting samples such as nasopharyngeal aspirate or stool that can be taken as outpatients on the spot and hopefully be able to provide a result? So this work has been really important and also informs other efforts such as improving treatment decision scores and other things to try and improve our clinical diagnosis with the support of what lab we have available for TB diagnosis. So I just wanted to mention, of course, that as you all know, this TB SPEED project, Unitate funded, is based, the primary investigation is based here at the University of Bordeaux, and it's really, really important in multi-centre study, looking at issues around decentralising care that we talked about, decentralising diagnosis, and improving diagnosis in those at-risk groups that we just talked about: pneumonia, HIV, and malnutrition. So these are important studies. So we want to strengthen clinical diagnosis. So just to finish, while we still don't have the right technology, the right diagnostics, the rapid diagnostic tools, we still have to rely on clinical diagnosis. And I think this can be strengthened, including at the peripheral settings, including at the primary healthcare setting, including at the secondary district hospital setting. And Eric and myself and others, and Marilyn, we've all been involved in a lot of training to give health workers the confidence to be able to manage TB in children in terms of diagnosis and treatment, including those children presenting with pneumonia. And so through the union, we've developed job aids as desk guides to support health workers and online freely available training tools to be able to support that. And we've rolled this out in Uganda, and in doing so, in rural and urban Uganda, with focus on strengthening services at the primary and secondary care setting, there's been a marked increase, a 2.4-fold increase in diagnosing child TB cases, but also an increase in adult TB cases, and an increase in bacteriologically confirmed child TB cases as well, while at the same time improving treatment success, treatment outcomes, and also successfully introducing into households preventive therapy such as isoniazid preventive therapy with good uptake and good completion. So I think the Ugandan Detect project has actually been a nice health system strengthening implementation project showing some success, and we're hoping to build that further both in Uganda and the African region. This is just a graph to show, compared to non-intervention districts at the bottom, how it was a pre and post evaluation, the numbers increased in Uganda. Sorry, I thought I was, yeah. Hypoxemia. I'd forgotten I wanted to talk. Back to pneumonia. It is actually quite difficult clinically to detect hypoxemia in a child with pneumonia. The clinical features that we are taught in medical school, such as cyanosis, for example, is really poor in terms of very specific but very poor sensitivity. And you have to become very, very hypoxic before a lot of children develop cyanosis. And you don't want to wait for that. You want to treat with oxygen when the saturation gets below about 90%. So the detection of hypoxemia is challenging, but of course now, more and more we have pulse oximetry, and that is becoming cheaper and cheaper and more available in countries. And a study done by my colleague in Melbourne, which was in hospitals in Papua New Guinea, where there's a lot of severe pneumonia, showed that if you introduce training, pulse oximetry and oxygen availability, you could actually reduce pneumonia mortality by 35%. So that was in a particularly high burden setting, but that's a very impressive reduction in mortality. And it makes sense to any of us who know hypoxia. It's a distressing symptom in any young child or in any of us, but it's actually really important to treat. So what the next study that we've done was in Bangladesh, where we've also done a study looking at the role of CPAP, providing some positive airway pressure using local tools that can be made from just tubes, old drink bottles, underwater, and a good seal, using the oxygen generated from an oxygen concentrator. So bubble CPAP. And this study, which was led by Mohammed Chisti, who was a PhD student with us in Melbourne and published in The Lancet, showed that the bubble CPAP group, the study was stopped early by the committee, the data monitoring committee, because it was showing impact. So the study was stopped early, so perhaps it's been criticised from too small a numbers, but it was clear that those receiving bubble CPAP had less treatment failure and death compared to those receiving oxygen through just normal flow. So CPAP is used often in resource-limited settings for newborns to prevent apnea and just give a little bit of support. But this is the first study to show that it can be used effectively in young children with pneumonia between 2 months and 5 years of age. And so that was, I think, a really important finding in terms of, and this is using locally made cheap material, just the oxygen concentration. There's a group in Melbourne. One of the problems of oxygen concentrators is that they require electricity. There's a group in Melbourne, there's some work that's been done in the Gambia and other places that now link up their oxygen supplies to solar energy, but solar energy is only for half of the day. The Department of Physics in Melbourne has come up, I don't understand the physics at all, but it's really clever, and they've implemented it in as a proof of principle in southern Uganda, and they can draw oxygen from running water. And so all you need then is a running water and you can draw oxygen. Believe me, it works. So they've actually now put this into the context of actually working by a river. Sorry, time. So to finish, to summarise, this is work from Malawi we did some time ago of just trying to reduce deaths from severe pneumonia in the hospitals. Just by health system strengthening, improved oxygen, providing oxygen, making sure antibiotics are available, training the health workers around management, you can do a lot. That's a large number of cases in all 24 district hospitals. And it's really, really critical to recognise that while we're still chasing new vaccines and all of these other things, there's still a lot we can do with implementation in the resource-limited setting to improve outcomes for child pneumonia. So, thank you.